Record. I'm Dan Grabois, and this is my podcast, $2 Broom, in which I talk with interesting people about the interesting things that they do. And today I am talking with Dr. Michael Traktman, who is also a friend of mine in Madison. Michael, hello, and welcome to my podcast.
Hello. Thank you for having me.
It's great to have you here. I wanted to talk to you because, first of all, it's always interesting, but I have watched every episode of The Pitt
Totally.
and started
Yeah.
over again.
Yeah. Oh, you started over. Nice.
I started over and watching it, I'm sitting there wondering, is this real life? When I see a show about musicians, I can tell it's not real life.
Right. Right.
So I want to talk about generally about your experience with emergency medicine, but as a starting off point, let's talk about The Pit because I think it's become a real
Let's
hit
go.
show.
Yeah.
So, have you seen it?
Yes.
Did you
Yes.
like it?
Every episode, I do like it. I like it a lot. It's great. It is realistic, although no emergency room physician works that hard. Like you don't have a day like that. That's crazy. That's insane. Like that first season with a where you're doing incident command and you got a disaster right at the end of your shift. That's insane.
Mm.
But that's Hollywood. But it is very realistic. I think honestly the most so when people ask me what I do, it's really, I'm going to tell you right now, it's really, really difficult to communicate what I do to people, my friends and family. They really don't. It's really hard to tell them exactly. It's just too difficult. We do some really tough stuff. We're telling people they got cancer. We're telling fathers that their daughters are passed and their wives and family are, this is hard stuff, right? So the hardest part that I think that show captures is the emotional part. That's the part that I think that they really do get. Like we all have PTSD. We joke about it. That's what we do. We use humor in the ER mostly to kind of help ourselves get through what we do. And I'd say like the emotional, that part where you're really touching people, really it does affect us. It does. I don't care what anyone says. It totally does. And here's the thing: the more you do, the more it affects you, but the better your outcomes come. The better the outcomes occur. They just do. I can't. I guess I can't explain that part, but it just does. When you really connect with people, it makes a huge difference, and your job satisfaction goes up. But a lot of emergency physicians, they shy away from that. They do, you know. But as you saw on the show, Dr. Robbie does not. He totally dives in head first, and he absolutely tries to connect with every patient, as well as he has this like this this shield, if you will, you know,
I
which I
think of it as armor. Some of the doctors have armor,
yeah,
some of them don't. Some of them have so much that they don't allow their true self to be seen ever.
they capture that, they capture that, and what's sad is that those people really never they actually don't see themselves either. Sometimes it's so like when do they get to be them, right? And so I went through a really hard time in my career where I was doing that, and I burnt out really fast. Well, I wouldn't say fast. I'm pretty tough, I guess, but it took me about 10 or 15 years, and then I was like, I can't do this. This is, and then what I realized was that I wasn't connecting with people. I wasn't um, putting my heart and soul into it, if you will. And then I started doing that, and I did. I started to really connect with people. My job satisfaction went up. The burnout, it's why would I be burning out? I just love what I do now a lot more. I've always loved what I do, but now I really love what I do. Towards the end of my career, it's really kind of nice. So,
That's beautiful.
yeah,
One thing that struck me and has struck me in my own life as a patient, which I haven't been much, but a little bit,
yeah.
is the angel-like quality of the nurses.
Oh, for sure. Yeah,
And
yeah,
also the incredible depth of knowledge. I mean, the nurses really are teaching the medical students a lot of
yeah,
stuff,
yeah.
all in the guise of not teaching them anything.
Right, right.
I mean, there's
Well
nothing
said.
didactic about what they're doing. They're just these repositories of knowledge and sympathy.
And that's the thing is that that's where I learned from. That's where I learned how to be empathetic and sympathetic towards patients, which is what they need in their worst moment, right? And the nurses are everything, you know. They it's a great way of putting it. They're a repository for compassion, you know. And they don't do it for the money, that's for damn sure, you know. And they're doing it because they just, I mean, they're just meant to be there. That's the only way I could say it. Those people are just meant to be there. It's
Hmm.
pretty, and it's beautiful to watch too. It's great to be around all the time to see people doing things that they're meant to do, you know. And not everyone's meant to do that. It's a tough place, you know. To be an ER nurse is not an easy thing to do. And Yeah, there's a huge skill set that you need. Um, and it takes a while to get there, you know.
One thing that really strikes me, because most of my career as a musician has been playing chamber music, so playing in small groups where there's not really a leader, although there people step in and out of leadership roles, but there's a sense of teamwork, often unspoken, but it's so collaborative. And
Totally.
especially in the most dire emergency situations in the show, you really feel that teamwork happening. Everybody's calling out orders, and somebody asks for a medical tool, and it's right there in their hand already. And
Yeah.
people understand each other and understand their role. So how true to life is that? And then
Yes. That,
also,
yeah.
along with that, how true to life is the level of cluelessness of the medical students coming in to become doctors.
Oh yeah, that's fun. Yeah, July. You never want to be in a teaching hospital in July when they first get out of medical school. That's a dangerous place, but they're
Mhm.
usually well supervised, so you're probably good. But um, so the well-oiled machine is one of the most fun things to do. Yes, life is on the line, limb sometimes, but yeah, when you're in that situation, yes, there is a leader, but everyone there is a leader. If one person decides that, you know, they're not showing up to work that day, the whole thing falls apart, right? And so, like, the respiratory therapist is just a respiratory therapist, right? No, 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 no. They're key in that moment. That they're key, and same with the med nurse and the documentary or whatever you're doing, whether it's a code or whether it's I mean, whatever the case may be. Yes, the well oiled machine is super fun to work with. Um, it's something, and I try to do that in other areas of my life, and it's really hard to replicate. Um, the
Well, of
med
course, when you
students.
when you get a good team, it's
Oh
just an
shit, yeah.
incredible feeling.
Yeah, yeah. It's and you develop that. That's what you do is you start out and you're not the greatest, and then you work it through and you get better and better and better. And we all want to get like that moment of joy and glee, if you will, where like you saved life. You know, it's pretty cool. It's
Yeah.
pretty awesome.
And then there's on the pit, there's the one young woman whose name I can't remember, who's quite abrasive and not really able to operate within the team structure. And like I'm just sitting there waiting for disaster to strike. The one who has nicknames for everybody that are
Oh no, 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 no,
daunting.
no. Okay. So understand her, right? She is definitely part of a good team. She is. But she's just, look, she gets it already. She's a badass. And she's not gonna put up with people that are not badasses. Because you kinda have to be a badass to work there. And it's not I'm not being conceited here. I'm not trying to be like I'm a badass, but no, 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 no. It's not like that. It's like you actually have to be a badass to work there. And she is. And she recognizes that without having to say it. And a lot of people, that what she can't stand is these whining people that are just whiners. She's like, look, you need to step up here. And that's really that happens a lot in the ER. Now, what we're talking about a lot of times, what we're talking about now is the top level, right? When we're all, pucker factor of 10 and, there's a thing happening. But I'll tell you, Dan, most of the time we're just kind of chilling, waiting for that to happen. It doesn't happen in every shift. It happens when it does. You never know, but It doesn't happen as often as you'd think. Like that show, it happens every 5 minutes,
Right.
and that's a major trauma center. I get it. And major trauma centers, a lot of them do operate somewhat like that, but yeah, usually not that, even that.
So
The
even
med
a big city
students,
hospital like in New York City would not be that much of a friend.
yeah, Cook County, Sinai Grace in Detroit, some hospitals. I don't know the ones in Manhattan that are like that, the trauma centers, but yeah, for sure.
Well, tell us about your education. You obviously went to medical school
No.
and then decided to become an emergency room doc. How did all that go?
Um, Actually, when I decided I wanted to go into medical school or be a doctor, I wanted to be a surgeon, and because I love working with my hands, and I was on my surgery rotation as a med student, and I was at the hospital that I was born in. It was really cool, and I was with this surgeon who I just thought was the best thing since sliced bread. I'm like, I want to be like that guy. That guy is the guy I want to be like, and so I show up Saturday morning to grand rounds, and it's his grand rounds. This is his job is to run this. And he's on what those remember those desks? It's like a folding chair with the desk kind of folds over the top. Okay, so he's sitting there with his elbow on that desk, and he's like out. He's sleeping, and I'm like to the chief resident, I'm like, dude, what's up with Siegel? Like this is his rounds. Why is he not? And he's like, oh, he was up all night doing surgery. And I was like, oh, huh. And then I met a couple of surgeons that used to joke around about like, yeah, I got kids, but I think I have three. I'm not sure, two, three. I'm not really sure what their names are. And they would kid. And I was like, that's not what I want to do. That's not what I mean, it's being a physician is not, it's just what I do. It's not who I am. And I've always felt that. So, and then yeah, the thing about emergency medicine is that it's very quickly, you could tell you need to have a couple of different pathological diseases in order to be a good ER. You got to have ADD for sure, like bad.
Why is that?
Uh, well, we all have it. It's hilarious. Imagine being around 15 people that we all have ADD.
How does it express itself in your workplace?
You're constantly bopping around from patient to patient. You have 15 minutes of fame in each one. You're constantly, you know, moving. And so it works for you, you know, it totally works for you. You could focus. Attention deficit disorder has the ability to focus really, really like hyper focus. It's a superpower, and you can hyper focus for like maybe a couple of minutes, which is what you need to do. So it works for all of us. Yeah.
So you, after seeing what the surgery life as a surgeon would be like, what made you then gravitate towards emergency medicine?
Well, I think I'd love doing the surgery too. I think I would have loved that because I love working with my hands. But emergency medicine, there's a lot of procedures. There's still some minor surgeries, if you will, and a lot of procedures. And so that, and also, um, uh, surgery is a little slower, and I like the faster pace. I definitely fell into the right thing. And that's
Mhm.
what happens is that as a person, you're going through your training, and then you find someone or some specialty that just is like that's the one. It just fits, you know, it just does. It's usually a person, and you're like, I want to be like that guy,
Mhm.
that girl, that
Mhm.
person, you know.
Well, speaking of that guy, that girl, are there any kind of gender disparities within emergency medicine? Is it mostly men or mostly women who gravitate
No,
towards it?
no,
Nicely mixed.
yeah, it's very mixed. Yeah, yeah, just as much. There's male nurses. There's yeah, it's all across the board. You know. Yeah,
It's
but there is a
sorry. Yeah.
no. I was going to say the only thing that is consistent is that there's what's the acronym? Um, Badford wait badass Bafford. That's it. Bafford. Bad ass friendly, or you can substitute that word, ER doctor. Yeah,
Hmm.
I've seen license plates of the youngins that put that on their license plate.
Hmm.
It's part of the thing. It's just part of the thing. There's a little ego involved. There is, but mostly tremendous amount of humility.
Right.
That medicine will humble you fast.
Yeah, there's got to be a failure rate because not everything is survivable.
Correct. People die. Yes.
How do you deal with that? How do you, Michael Traktman, deal with that?
Okay. So, uh, it's mostly faith based. Um, so I've seen people live that are not supposed to live, and I see people die that I feel like are not supposed to die. And a lot of time, and 100% of the time, what I say is, "Hey, listen, I'm just a conduit. The big guy upstairs is making those decisions. That's well above my pay grade. I do everything I possibly can. I do the best job I possibly can, and it's crazy. I have seen people like, oh my god, I cannot believe that person lived through that, and then I say, well, that's what they're supposed to do. You know, I wish I could. I'm not taking credit for that. That the big guy upstairs is taking credit for that. You know.
Does that help you when somebody dies that you a little bit less feel like you don't have to take the blame for it?
Blame and responsibility is a difficult game to play in my field. You know, um, I didn't get him in the car. I didn't force him to drink. I didn't force him to drive 100 miles an hour. I didn't force him off the road. I mean, there's so many, right? By the time they get to me, there's a lot of factors that get them there, you know? Um, and that's the thing about life is that, what got you where you are right now? I mean, you could talk about your whole history of, musical training, but your ancestors got you here too, you know? We're all building on top of that. And so that's all these people are doing too. I'm just, you know, just to stop along the way. Hopefully helpful stop. You know.
Yeah. Um, I was thinking if you are, let's say, you're a surgeon and you specialize in kidney transplants,
Yeah.
then what you're doing every day is transplanting kidneys. But if you're an emergency room doc,
Yeah.
you must have to have this incredibly huge array of uh, things in your bag of tricks because one day you get somebody who's got an ingrown toenail that's completely infected, and one day somebody's had a car accident and their arm's been taken off in the accident, and then one day somebody has a brain injury, and so on. Is just different all the time.
Yeah. Yeah. We're definitely. Uh, how do you say? What is that saying? The man of many talents, master of none.
Jack of all
Jack
trades,
of all. Jack of
except
all
that you're
trades.
also a master of those things.
Right. Right. There's a lot. So what we know is we know just enough about orthopedic surgery to get them into the OR. But I can't do the orthopedic surgeon. I can't
Mhm.
do the surgery. I know just enough to know about, appendicitis, but I can't do the appendectomy or the cholecystectomy or you know. So, so when I call those people on the phone, I know what to, I talk their language, but I can't do it, you know.
Let's talk about the language of doctors. So, getting
Uh,
back to the pit,
so,
many scenes in the show, I don't know what they're talking about.
mm.
There's a whole,
I wondered about that. I wondered, like, when the layman, like, musician, perfect, you know, what's that like to watch the show and you have absolutely no idea what they're saying? Like, there's little nuances that they talk about in little tiny things that they say. And I'm like, oh, that was really important. But, like, how would anyone know that that was even critical? And like, what's it like? I'm just not to turn this interview around on you, but what's it like for you to watch that show and not know anything about medicine?
yeah. I mean, I have to,
Why is it intriguing?
I still get that there's a trauma and that the people who are dealing with the trauma, the doctors and nurses understand what to do, even though I don't understand what they're saying. I mean, it helps that they're acting, so they sort of, there's clues that probably wouldn't be given in an actual emergency room because they're kind of acting to clarify, maybe, I don't know, or maybe not.
Like
Um,
what?
but there's
No, no. Everything they're doing is exactly the way they would do it.
okay.
They're not acting
So,
anything.
yeah, so a lot of it just goes over my head.
Okay. So I've seen interviews with Noah Wiley, and and he will, like, throw it just in an interview. He'll throw out a line and he has no idea what it means. You know what I mean?
Is that Dr. Rabinovich?
Yeah, yeah, yeah.
Oh,
Right. And and it's just, I mean, he throws it out really well too. I mean, he articulates it perfectly. Pronounces all the language in medicine is something that you develop over time. It's not something, that's why it takes so damn long to learn.
yeah.
It's not just it's everything from the first day of biochemistry, year one in medical school, all the way through, 15 years later when you graduate from residency.
I want to talk about that process, but before we do, I'll mention that I find that doctors, when I'm in a doctor's appointment, they speak to me in medical language, and I frequently say,
Yeah,
"You have to speak
yeah.
English with me because I might not know that a patella is a kneecap." And
That's
when
a total
I
pet
mean,
peeve
I
of
do.
mine.
Sorry.
That's a total pet peeve of mine.
Yeah, I don't like it. And when I do a lot of public speaking to people about music, and I don't talk about the dominant chord resolving to the tonic because I know that nobody knows what that means.
Yeah, I don't know what you just said.
Right, exactly. So whereas to a musician, I'm like saying 1 + 2 = 3. So
Really?
why
Is
can
that what that
doctors
means?
not remember that we don't know what this stuff means?
Right. Right. So here's the thing. Uh, it's not dumbing it down. That's not what I do. What I do is I take a very complicated situation, subject, or thing, a very complicated uh, material. Okay, someone that has. Uh, I'll give you an example. Okay, uh, there's a disease process you may be familiar, diabetes, right? So there's two types. One of them is called type 1, one of them is called type 2. So a type 1 diabetic comes in, and they go into DKA, okay? And hold on. And they require, intubation and insulin drip and a number of different laboratory evaluations, and then they're going to be admitted to the ICU. And that was a
So
quick blurb of presentation to admission, right? And then
I
what I'll
understood
do,
everything but DKA.
right? Well, hold on. So what I'll do is I'll say to patients and families, look, this is called diabetic, which you know it is, ketoacidosis, and then I'll explain a little bit about what happens when, you're vomiting or diarrhea, and you use up, and you just basically you go into a state of ketosis, right? And then I'll sometimes explain it like the South Beach diet, or those diet programs where people want to try to go into ketosis, and a little bit of the metabolics, so they understand. And the idea is, it's not about dumbing it down, it's about explaining it in a way that they understand it.
Yeah, totally get that. That's how I
And that's
wanted to
it.
talk to.
And that's it. And the thing is that it doesn't take that much time. It's critically important. It's super helpful when the patient understands it, as well as family or friends or who's ever with the patient, you know.
So I want to talk about medical school, medical training. I want you to take us through the process because most of us go to the doctor. They've been through it. We don't ask them about their school years or what
Yeah.
they learned. But as a starter warm up question, I'll ask: is there any instruction in bedside manner in how to talk to patients?
You want me to start there?
That's where I
No.
want you to start.
Well, okay, I shouldn't say no. There is. There is. Okay. So what happens is that at around the second year, you're not out in the field yet. Um and they've taught you how to take a good history from a patient and do a physical exam, and then they'll start practicing on patients that are mock setups, right? Okay, and so there'll be an instructor there, okay, and they'll give you questions to ask, right, so that you're getting all the data, right? And then once you understand how to gather the data, then you start to develop your own way of gathering the data. And then they try to teach you. It's really hard because you're asking me, are they teaching you how to listen, right?
That's a
Are they
great
teach
question right there. Are they? I'll ask you that question. Are they teaching you how to listen?
they great question, Dan.
Thank you.
Um they don't what they do is they teach you how to gather data, you know. They teach you how to gather data. Um they uh, teach you how to uh, be well. It's really hard. It's hard because they don't sit there and say this is how you be human. This is how you're going to interact with patients. They don't. They just kind of guide you through it, and there is some. I'm not going to say there's none, but there's some instruction about trying to connect with the patient. But it's sometimes difficult to pick up because there's so much more that you have to know.
Right.
There's so much more that medical school is not that it's hard, it's just that it's voluminous.
Right. All
That's
right. So
mostly
let's
that's
dig
what
into medical school. So you finished one has finished one senior year in college, taken the MCAT, been
yeah.
accepted at a medical school.
Yeah.
It's day one.
Woohoo!
Day one, year one. Yes, they know they're going to be a doctor. So it's now
Yeah.
it's day one, year one of medical school. Just in broad strokes, tell us about year one. We'll
I
go through
mean,
the process.
you're okay. So medical school has changed over the years, and they went to systems approach, which is I think what they're doing now. I'm not 100% sure, but when I was going through, the year one was anatomy, physiology, microbiology, neuroanatomy. There's a little bit of psychiatry in there, and it's didactic learning, right? So you have books, and you have lectures, and you have notes, and and you have exams.
You're in a
Um,
classroom, just like anywhere.
you're in a classroom with about 150 people, right?
Okay. Okay. Big lecture classes.
Big lecture classes. That's right. And there's a note. The way it works is that um, there's labs too. So there's some hands-on stuff, and all kinds of hands-on stuff. There's smaller classrooms for like um, well, you'll do little mock cases towards the end of second year, and a professor will be in there. They'll say this is, and they'll have an actual person that is an actor that does a patient, and you'll go through that case, and you'll try to figure out the diagnosis and treatment. You know, and you have your like three other buddies that you're med students, and you kind of they allow you to talk it through with them. So everybody gets the diagnosis is the idea, and because medicine truly is a team approach, is you'll never like be alone. I guess if you're a radiologist or a pathologist, but even those guys talk amongst themselves too. They absolutely. Um, so
So
that's
I'll just jump in to say when I was a student in school, I was born in 1964. So there was not really this notion of teaching teamwork. That was cheating if you collaborated with somebody else. But I feel
yeah,
that has changed a lot.
yeah, for sure. Yeah, and that's the other thing is that when you're out there like practicing, you can use any and all. There's no such thing as cheating.
Right.
You could use any and all resources. In fact, it's encouraged. Look this up, look that up, ask this person, you know. Second year is similar, but it's more systems approach. That's the pharmacology, and they do the way they did it when I was going through. Is they had the cardiology, pulmonology, and all the different specialties, if you will, and then
Why
you
are you
did
calling this pharmacology? What do you mean?
so like in the cardiology month that we or whatever how long ever that was, we learned all the pharmacology of cardiology. We learned all the anatomy. We learned the physiology, and then what we were learning really was the pathophysiology within the cardiology section,
So like here's the
and all
heart,
of all the
here's what
drugs.
makes up the heart, here's the kind of tissue, here's how it
Right,
beats, here's
right,
how many times it's supposed to beat, here's what
right,
can go wrong, here's what
right,
how you treat it.
right.
Okay.
Right. And you went through each, every, I don't know if it was, I don't know how long it was. It was whether it's 6 weeks a section, and then we did, cardio, pulmonary, um, nephro. That's kidneys,
Yeah. So like
um,
digestive system, that kind
digestion, GI, right, all that stuff, right.
of
And so, and then third year, to me, that was the most exciting because you're done with classroom, and you're out in the hospitals, and you're going every month. You're on a different rotation, and that's when it got super fun.
So
That's when I
you're
was
not a
like,
doctor yet, though.
no, no, no,
You're a medical
no.
student.
Yeah, and if you'll notice, like in the pit, they'll talk about M1, M2, M3, and M4. That's
Yeah.
medical student one, two, three, and four.
Okay.
And
The 4 years.
then they'll talk about R1, R2, R3, and R4. That's a resident,
Okay.
right?
Okay. We'll get to the resident part because we're
Yeah,
in year
so
three now.
I'm in M3 now, and I'm in I think my first rotation was internal medicine at this great hospital, and it was very structured. Okay, super structured. They told you what they expected, right? It wasn't like, you know, you had to guess. You need to be here at 5 a.m. and you need to round on these 10 patients. And then you need to be at pre-rounds, which is in the cafeteria, at 6. And you'd present all your 10 patients to your resident, that would be an R2. And then you went from there to actual rounds at 7 a.m. with the attending in the room and the chief resident in the room. And then
Okay. Yeah.
you
Take us those are terms I hear all the time, the attending and the chief
Okay,
resident.
so the attending is, completed residency, and he's a full-fledged doctor. He's done with training.
Okay.
That's an attending.
Or
A
she.
resident is in residency after med school. They are doctors, R1 through R4. Well, in surgery, it's R6, right? You can go 6 years of residency. And then the M1 are the medical students,
Okay.
right? And when you're in rounds at 7 a.m. with the attending, right? Everybody's in the room. There's probably, in your team, probably 20 or 30 people in that room.
So if I'm a patient at the hospital at that time, are 20 people going to come into my room in the morning?
Yes, yes. Well, we don't. Okay, so sometimes we would go bedside rounds. Sometimes we do that depending on the rotation. Certainly ICU, we did that. That's the intensive care unit, but the a lot of rounds. Don't forget, I saw the patient at 5. My first year resident saw the patient at 6, and my chief saw the patient at 6 as well. And then the attending gets presented with all of that. Now I'm presenting at 7 a.m. as the med student. But if I screw up, then they'll go to my first year resident because he saw the patient too. And if they screw up, then they go to the chief, and he better know what the hell's going on.
Right.
And then because technically the attending is responsible for that patient, right? It's their patient that's admitted to the hospital, that they're taking care of. Then the attending will go and do rounds, after at 8 o'clock, we're done and we go do our day, and the attending will go out and they'll go to clinic, but they'll go and they'll do rounds and they'll see the patients as well. A lot of times that's the way it'll happen.
And what is your day then that you go and do?
Right. So at 8 a.m., I'll go and I'll check labs and go. This is in the hospital. We're dealing with like internal medicine. It depends upon what rotation I'm on as an M3, right? Because we're talking third year. So, I'll go check labs well, I checked labs before that. They came out at 6. So at 7 a.m., I was able to communicate those labs to the attending. And so I'll go check. There's like a whole list that they'll tell us what to do. Oh, in bed 214, the potassium was high. You got to go and make sure he gets, treatment for that, you know, or this person needs that. And my chief, actually, my first year or second year resident will give me a list of things to do for the day till about noon. And then at noon, um, we would go and we would have lunch at the same time. Um, um, uh, there would be a lecture of some sort, you know, a noon lecture, and uh, after lunch, um, there'd be more things that you had to do. All that list is still not complete. And during that time, all the you're getting paged, called, and you're like, you got to do this, you got to go here, go there, and then you're also trying to figure out um, how to learn on. That's the other thing is that you're also trying to figure out how to learn. As an M3, you're just totally, completely lost.
Right. I
You know,
remember in college classes, by the time of the final exam, it was really hard to remember the stuff that you had learned in September because
right,
now it's, late November
right.
and so, but it sounds like as a doctor, you're there in the hospital, so you're seeing stuff over and over and over, even though it's a ton of material.
Right, right. But here's okay. So you need a system. You need a way. And so, because a lot of times, you see pancreatitis 4 or 5 times, right? But how do you remember all of the little nuances,
Right.
So what? So I was taught very young. What you do is you pick one case every day, one case, and then you go home and you read about that case, right? And you don't have to read for very long, 15, 20 minutes, an hour, whatever, about just pancreatitis. And I used to take notes and I'd have a little notebook. My God, we had these, little white coats as a med student. They only go up to your hip. It's like a jacket, it's like a sport coat, but because that's, the length of the coat could you could determine, where you were in your training because the attendings, the full fledged those guys, that coat was all the way down to the ankle. You know what I mean? It's like
Is that system still in place? So in the hospital,
We
like,
COVID, we trashed a lot of the white coats. Recently, I started wearing it again. For a lot of one of my colleagues was like, people listen to you more and all that stuff, and I was like,
and get
okay,
reassured by that probably as well.
sure, sure. I tried it for a little bit. But I like one of the greatest things about emergency medicine is I get to wear pajamas to work, and a smoking jacket, which is the white coat. But as a med student, you have all these pockets and you're putting all these notebooks in it, and that's what I used to keep. Today, it's all digital. I'm sure that you're using a lot of their on their phone,
Mhm.
to because you can get to your files right on the drives, cloud stuff.
And so
So
after your M3 year, you
yeah,
must have a lot of knowledge, but
yeah,
you haven't
still
put it into
clueless.
practice. Still
No, no,
clueless
no.
away and haven't put it into practice.
Oh no, you're so okay. So what you're learning to do as a medical student is collect data. You're learning how to collect data. Okay. As a resident, you're learning how to interpret the data and putting it all together. And by the end of your residency, you know how to collect. You're really good at collecting data, and you're really good at interpreting the data and knowing what to do with the data. And that's what being a physician is we bring in the data, we interpret it, we understand it, and then we kind of that's when the artistry comes in afterwards about how to use it, if you will, treatment, right? So M4, you're still collecting data, but you're getting really good at it, you know. And we present patients to a lot, you know. My chief resident one year told me, what you want to do is when you're presenting a patient is you want to take this present, like a Christmas present, and I'm going to put it on the table, and it's a perfectly wrapped present, right? Perfectly, the bow is perfect. The wrapping paper, you can't see any tape whatsoever. It's like but when I put it on the table, my chief resident, they know already what's inside with the first two sentences. And I'll give you an example. You ready?
I'm ready.
All right. 17-year-old male presents with right lower quadrant pain, fever, chills, and looks sick. What's the diagnosis?
Pneumonia.
17-year-old male presents with right lower quadrant abdominal pain, hurts down in the right lower quadrant, fever, chills.
Appendicitis.
What? There
Appendicitis.
you go. That's my man. Right. So the idea is that in the first sentence, boom, they know.
Hmm.
Right. Right. And
So
then
this is one of the frustrations as a patient with the data-based medicine is I often feel like I'm not a data point. I'm a person. I may not be like all the other data. Everybody's different.
right.
But I guess there's not a better way to practice medicine than to know the
Oh no,
data.
that's just we're only in we're in M4, bro.
Okay, so we'll get there. I'm jumping
Remember,
the gun
we're
as usual.
clueless. We're completely clueless still. We're
Okay.
still clueless. You're
Okay.
not a, and that's the thing is that eventually, right? Look, Dan, when you first picked up a horn, could you make a sound?
Yeah, but it was not anything anybody would want to hear.
Exactly. Exactly. How long did it take before somebody was like, wow?
Yeah, that's a while.
How long?
Uh 5, 6 years.
No, longer than that. Before somebody was like, wow, that is beautiful.
Yeah, 5, 6 years people were saying that, I think.
Okay. Well, you were a prodigy, probably.
I was not a prodigy. But I mean, yeah, I see what you're saying. It takes a lot of work.
It takes, and the thing is that you're talking about the artistry of it all. You know what I mean? And that takes. I mean, eh, I don't know. I just feel like medicine is very much like almost anything else. I really do. Like you got to know. I know you got to know a lot. But the thing is that so do you as a musician. So do you as a computer engineer or programmer.
Right.
I mean, they got to know a lot
Yeah.
and they take
You
for
as a
granted.
plumber, right? It's not you as a plumber, you as a bicycle repair person, you
Exactly.
whatever. They all of everybody has their specialized knowledge.
Right. And as they as they do it longer and longer and longer, they're still learning,
Right.
you know? It's just that we learn it honestly in a short period of time.
Right.
And then you just say, okay, wait, there you go. You're a doctor. That's it.
Right.
And then you get out there and go. And it's practice, as just like anything else.
So we've gone through M4. We've gotten very good at collecting this data. We
Sure.
understand it. We now know the jargon,
Little, yeah. We could
medical
speak the
talk.
language. We could speak the language, but we're still fumbling. Intern, completely clueless still. Still
What's
clueless.
wait, intern is what? That's
First year residency.
R1 is called an intern?
First year residency is an intern, right?
Okay.
Right. And but you're a doctor.
Right.
Scary. Scary. Right.
Right.
And so yeah, you graduate from med school and you get a residency and you go to work and you get paid, which is cool. Not a lot, but
But
and
you've got a
then
lot of debt, right? At this point, med school
my
is
God, a
yeah.
ton.
Yeah.
A ton.
Okay.
Yeah. Yeah. Shout out to the government. Let's make that free.
Yeah.
Yeah.
All education should be free,
It
but
should be. It should be.
that's for a different podcast.
Podcast.
Yeah.
Yeah.
Okay, so you're now making some money. You're an R1. You're called an
Yeah.
intern. Your code is a little longer.
Little longer. Longer the coat.
You know how to speak the language and collect the data.
Yeah.
But now are you treating patients?
Yeah, you're treating patients. You're actually, I remember my first night of call as an intern, and I was walking around the hospital. The only person in the hospital other than me was a resident that was running the ICU, and I was running the floor, right? And at the time they were using pagers, right? So my pager was going off all night, and it was be stuff like, can the guy in 412 have some Tylenol? You got to understand, nurses know exactly what to do, but they need the order from the physician, right?
Mm-hmm.
So I was the guy,
Mm-hmm.
and I was just running around from floor to floor, you know, um, basically doing whatever the nurse told me to do. They would guide you totally. And if I didn't know what the heck to do, then I either walk to the ICU or I'd call the ICU and I'd say, I need to speak to the resident, and I'd try to explain to I don't understand why this guy in 14 have toast or not? I don't know.
Mm-hmm.
Stuff like that.
It seems really smart that where there's this incredible trove of stored knowledge with the nurses that the system is set up that they can actually instruct you. Like you probably learn a lot from them
Oh
as
God, yeah, you learn a
R1.
ton.
Yeah.
You learn a lot. Yeah, as long as you're nice.
Right.
If you're nice enough, because if you're not, they'll rip you to shreds.
Mm.
Yeah, they'll throw you to the wolves pretty quick. If you get cocky or think you're all that, and then you're not, and because you're not.
Right.
uh, it's kind of fun to watch as an outsider,
Right.
as like
So you're an R1, you're not doing a kidney transplant. You're probably not doing surgery, but you're kind of getting more involved with the patient.
Yeah. You're developing treatment plans and what we call differential diagnoses. That your list is a little longer about what you think it could be, and then you're bouncing that off of your R2, who's bouncing it off of the R3, and it just goes up the line, right? Until they
Mhm.
decide, okay, well, it's this is like, and then we start they'll tell you, okay, start an insulin drip, and then I'll be like, at what rate? What? And then they'll tell you, and then and then you very carefully, at least to write it down, and then make sure it's entered correctly, and check with somebody else, and do that. It's really scary at first. It's super scary
Right.
when you writing orders and stuff like that, but as you get to R2 and R3, you become more facile and comfortable, and then and again, remember you got all these people around you, you know. Um, I do remember that one night when I first started as an intern, my first year residency, and I was walking around the hospital, and I'm like, oh my God, I'm the only one in this hospital. I'm the only doctor in this hospital. This is cool. This is really fun. This is great. uh, not really understanding that, there's lots of other people that are, kind of overseeing me. But if anything were to happen, I would know about it, which was kind of cool. That's all. It was a
Mm.
smaller hospital, you know. I liked the community hospital program, more of a family. I really enjoyed that than a larger trauma hospital where the culture is, um, just tougher, much tougher.
Yeah. So presumably, without beating a dead horse, R3, R4, you're just more involved. You've got more knowledge. People are asking you questions now.
Right. That's right. They're coming to you. You're doing the noon lectures.
Hmm.
You know, you're making sure that the medical students are learning, that they're on track, that the interns are doing what they're supposed to do. You're the guy that's taking the leadership position and making sure everything's good, and your attending is checking with you, right? And it how long do you think it would take you to assess a horn player? Um, uh, you know what level they're at and what they're doing. 3 seconds.
5 seconds, five
Right.
seconds, maybe not that much.
Right. Exactly. Same.
Mm.
Same. And when you're an attending man, it is so fast. You just like, okay, all right, no, no, no. Okay, yeah. That guy's good, but we got to work here. We got, and then you start to, tease out what needs to get done, and you start to assign those duties to the residents and stuff like that. Hmm.
Okay, and now you've finished R4. You're
Woo! Yes, you graduate,
now, what are
and
your options?
well, the way it works in when you're done is probably around the end of your fourth year of residency. You've already looked, and you've already decided where you want to go. A lot of it's based on geographics. Some of it depending on what you do. Like I have a friend of mine who's a transplant surgeon. He went to Indianapolis. He doesn't live in Mid. He went to Indianapolis because that's where the transplant hospital is, right? um, Emergency medicine is everywhere, so kind of good, right? I can work anywhere. Um, uh, so, I decided to go where, um, Midwest. I wanted to stay in the Midwest. My wife's family's there, and I've always felt that those are the best people in the country, like you, Dan.
Yeah, like you. So now you work at a in a smaller
Hmm.
hospital, small town. You probably see a lot
Yeah.
of car accidents and stuff like that.
Yeah, there's basically a community hospital. We see about I think we're about 14 or 15,000 patients a year is our volume. That gives you an idea of how busy we are. Like a Cook County hospital in Chicago is like 170,000 patients. Is it that much? Maybe it's about 110,000.
Mhm.
Somewhere around 100,000, probably more, is a large trauma center, you
Mhm.
know. Um, let's see. Anyway, yes, we see our share, you know, 10% trauma, 10% peds, maybe 20, 15% peds, you
That's
know,
pediatrics.
pediatrics, yes.
That's like my son is having an asthma attack. My daughter
Sure.
um,
Well,
sprained her wrist.
well, those are urgent care complaints, but yes, as well as, you know, my kid can't breathe and there's something stuck in the throat to, congenital stuff. My kid has um, a congenital, like he was born with a heart condition and, he's on these machines and he has a trach and, I have to, there's all kinds of stuff that, depending on the population where they live, that come in. Anything from very complicated thing to he's got a bead up his nose. You know what I mean?
But with that kid, that boy who has the trach and all that, you probably know that kid because he's probably in there every month
Sure.
or two.
Sometimes, but a lot of times you don't. So, that's the whole thing. You get the history. And, thankfully these days it's so easy to get medical information from other hospitals. It's all electronic, you
Right.
know. And so getting those records were used to be hard. It was very important. And now it's a lot easier, you know.
Right. Because
Electronic
you just
medical
be
records.
faxing stuff all over the place.
Right.
And
There's no faxing. You just click, care everywhere and boom, there it is.
right.
You know, I got stuff from Portland. The guy was just, in from out of town, and he gets his care in Portland, and there it is. You
Wow.
you you see their doctors, you see their last appointment, you see the note from yesterday, you see the X-ray from the week ago. It's all there. It's great.
So let's see if we can do a little detective novel. Can you remember a recent case where somebody came in, you weren't exactly sure, you had to follow some leads, and then you figured it out?
Oh, so that happens a lot. Um, but after I don't know, I think it's been 25 years of practice. What I realized is that medicine jibes, always does, every single time. In other words, it makes sense. It all makes sense. And if it doesn't, then I didn't ask the right questions. I didn't get the good all I didn't get my data, right? I didn't get all the information and I didn't put it all together, but it always does. Um and so sure. Um let's see. Okay. Okay. So oh, there's so many cases that are floating through my head right now, but I guess the best one is that I could think about is this. Let me think about. Is it this lady or that? Let's say that. Okay, so this lady comes in. Okay, elderly female. She's like 80 years old, and she comes in with altered mental status. And so, uh, when I talk to her, she's not really able to talk to me that well. And so she's kind of slurring her words. But she doesn't have any what we call focal neurological deficits where she can't move her arm or half her face isn't moving or it's,
So it doesn't seem like a stroke.
it doesn't, right. But you're not sure, you know? So you follow a lot of protocols as well as a method of what I call an approach, right? So yes, I'll get the full history from the family, from the nursing home, and sometimes there's none of that. You don't have any of that. You just have EMS that brings them in, dumps them off, and you're like, I have nothing, right? So sometimes it is veterinary medicine where you just try to figure it out. There's no patient to tell you anything. They can't speak and they have no family. So that's part of it. But like in this case, she had family and they said that, she hasn't been eating a whole lot past couple of days and she's been throwing up and just not feeling right. Um, and it's been a day or two, a couple of days or more, you know? So, we go through the motions. Yes, I get all the CAT scans and so forth and the diagnostic testing of sort, and um, nothing, and everything comes back normal. But the urine was dirty, and the white count was elevated, which means that there's an infection. And it turns out grandma's just getting a bad urinary tract infection. But I had to, before I could make the determination that this is just a urinary tract infection, which can play havoc on the elderly, right? I got to make sure she's not having a stroke. What if it's both?
Right.
Right? So these are called stroke mimickers, and there's all kinds of altered mental statuses. And part of that, what we called, remember the differential, that's the thing that the residents started to increase in the number of diagnoses on their list. And so my list is really long, and then quickly it shortens up pretty quick. So I
Right.
check for aspirin overdose, Tylenol overdose, which in an elderly, did I take my Tylenol? I don't remember. Let's take more. Did I take my Tylenol? I don't know. Let's take more.
Right.
That kind of thing happens, right? So you check everything, trust nobody, check everything, so to speak.
Right.
And so eventually what we found is grandma just had urinary tract infection. We gave her some fluids, some antibiotics. She perked up right there in the emergency department. Everybody's happy and she gets to go home.
That sounds satisfying.
Super satisfying. So I love the detective work. That's one of my favorite thing to do. I really feel like that is super fun. Um, Using all the tools that we have there. You know, the complicated medical cases are my favorite for sure. Um, Believe it or not, trauma is pretty easy because it's very protocol driven. So you follow what we call ATLS protocols, and you're just following those protocols, and you know, and you just get the scans and you figure out what's going on. It's really protocol driven. Um, I like to think it's super fun.
Let's finish up with a brief discussion of the difference between public health and the health of Dan Grabois.
Okay.
So
Be
my
specific.
wife and I talked a lot about this during COVID.
Okay.
Somebody doesn't want to get a vaccine because they don't trust the vaccine because it's brand new. And from a public health standpoint, that's absolutely not okay. But they think,
Well,
yeah, but this is the health of me, John Smith.
mhm,
Now we're seeing it with measles vaccines.
yeah.
You have thoughts on all of this?
Okay. So, sure. Yeah. I remember when politics, it's so funny when politics gets mixed up in medicine because it's like oil and water. You cannot mix them.
Right.
You just can't. So you don't want to get a vaccine? Fine, don't get a vaccine. That's fine. You'll get COVID, you'll get sick, and you may die, but that's up to you.
Except that
I
you're going to give your COVID or your measles to your neighbors.
No, because your neighbors have the COVID vaccine that are going to protect them.
Mm-hmm.
And the measles have the measles, you get your shots, right? Now, does it suck that people have decided now not to get vaccinated for these diseases that we basically eradicated? So now those diseases are now popping up more? Yes. But who's getting them? The
The
people that
people.
are vaccinated or the people that are unvaccinated?
Right. It is. I know with measles, it's almost entirely unvaccinated people.
You know, what are you doing?
Right.
It doesn't make any sense to me. But
Yeah, it doesn't
again,
to me.
that's politics, and I don't. It was hilarious when they were trying to mix politics and uh, and medicine because you can't. It's literally you cannot. So we knew as providers, we knew that this is BS, and of course, you know, but people can be sold a bill of goods at any time.
Right. Yeah. Well, this is really interesting, and I so much appreciate
My pleasure, Dan.
all the stuff that you taught me because I don't know any of this stuff, and I guess I can kind of see why after 4 years of med school and 4 years of residency, speaking in this lingo, doctors might continue that with their patients.
Yeah, and really, you're not. I know that you're done in residency after 4 years or whatever, but you're really not 100% done until 5 years out. Then
Mm,
you're done. Then you're really polished,
right.
and that's what it takes. But yeah, you're, finding the humanistic connection. Um, it takes time. It takes time, but I think that's with any profession, even plumbers
Yeah, totally.
and musicians.
We had a plumber here who I asked him to show me how to change the inside of a faucet. He was a
Yeah,
brilliant instructor.
he what?
Amazing.
Oh, he's a great instructor.
Yeah.
Awesome.
There's knowledge in every field.
Yeah, yeah, yeah. Exactly. Absolutely. Yeah.
Well,
Well,
thank you so much for your time
this
and
is
all of
fun.
this great stuff. This was fun.
Super. Super. Thanks, Dan.
Thank you so much.
Yeah.